This video seeks to educate the viewer regarding the American College of Surgeons Operative Standards for Adrenal Cancer Surgery, which were first published in the fall of 2022. They are the first set of in-depth recommendations specifically focusing on surgical considerations when evaluating and deciding upon treatment of a patient with an adrenal mass, and the key technical aspects of adrenalectomy when malignancy is in the differential based on preoperative testing. These recommendations are relevant to providers from any medical specialty involved in the evaluation and management of patients with adrenal disorders. The American College of Surgeons Clinical Research and Cancer Surgery Standards programs are responsible for bringing together experts in cancer surgery, developing accreditation standards for surgical care, disseminating resources and tools that support implementation and adherence to standards, and educating surgeons and other providers. The Cancer Research Program oversees development of the operative standards for cancer surgery publications, which provide recommendations focusing on oncologically critical technical aspects of resection for different types of malignancies. The Commission on Cancer draws from the operative standards when developing standards to which hospitals are expected to adhere to remain accredited as a COC-recognized cancer treatment facility. Two staging systems have coexisted over the past 2 decades for adrenocortical cancer: the American Joint Committee on Cancer, and the European Network for the Study of Adrenal Tumor Staging Systems. While these differed slightly, they are now essentially the same. A new staging system for pheochromocytoma was introduced in the 8th edition of the AJCC Staging Manual and differs from ACC in that there is no T4 category. Sympathetic paraganglioma are included, and classification of metastatic disease differs. For the rest of this presentation, we'll refer to the 8th edition of the AJCC Staging Manual for both malignancies. The preoperative evaluation of a patient with an adrenal mass, especially one found to be indeterminate or suspicious on imaging for malignancy, is critically important. Beyond the history and physical exam usually pursued, adrenal evaluation requires special imaging protocols and biochemical evaluation. Several imaging modalities may be utilized singularly or in combination to assist in differentiating between benign and malignant adrenal masses. When surgical planning includes potential nephrectomy, a renal perfusion scan may be helpful in predicting postoperative renal function, especially in those with baseline renal insufficiency. A comprehensive adrenal biochemical evaluation is necessary to not only understand the potential etiology of the tumor, but also because any hormones found to be autonomously produced are utilized as tumor markers in those at risk for recurrence. A selective approach to testing based solely on clinical signs or symptoms is to be avoided, as 25% of patients with autonomous hormone production or frank excess have subclinical or clinically inapparent disease. Biopsy of an adrenal tumor is rarely indicated and should be discussed in a multidisciplinary fashion. If pursued in select situations, it should not be done so until pheochromocytoma has been ruled out to avoid hypertensive crisis. In those found to have hormone excess in the setting of concern for malignancy, there is a balance which must be found between taking time to optimize patients to decrease hormone excess versus getting to the operating room to remove the tumor. In those with hormone excess, multiple medications are available to assist in optimizing the patient for the OR when deemed advantageous. In those with malignant pheochromocytomas, there is nearly always time to gradually preoperatively block a patient using antihypertensive medications given the slow evolution of disease. Due to the rare nature of both adrenocortical cancer and pheochromocytoma, the usually very aggressive nature of ACC, and the complex multimodal management of both ACC and malignant pheochromocytoma, management should occur with multidisciplinary input. At a minimum, representatives from surgery, endocrinology, medical oncology, pathology, and radiology should be involved in tumor board discussions and care. Additional specialties provide value for the care of endocrine patients, some of which are listed here. All patients with ACC and pheochromocytoma should be referred to a licensed genetic counselor. While adrenocortical cancers and malignant pheochromocytomas originate from different cell types, the manner in which adrenalectomy to treat both types of malignancies is the same. The key technical steps described in the rest of this video apply to both types of malignancies. The primary focus during adrenalectomy when malignancy is in the differential is resection of the primary tumor to microscopically negative margins without disrupting the tumor capsule. Surgeons must make a decision when planning and conducting the operation as to whether or not they are treating the tumor as if it is malignant, as operations for adrenal malignancies are carried out differently than in tumors considered benign by preoperative testing. Resection includes maintaining the peritoneal lining and Gerota's fascia over the anterior surface of the tumor rather than accessing the tumor directly through the overlying fascia. The peritoneum and Gerota's fascia, especially on the right, provide an anterior margin unless there is invasion of the posterior liver. The line of resection should include the adjacent periadrenal and retroperitoneal adipose tissue to provide adequate margins. The area of greatest concern on both sides is medially, where there is minimal adjacent adipose tissue. Dissection should seek to take as much adjacent tissue from over the vena cava and adjacent to the aorta as possible, rather than simply shelling out the tumor from the surrounding adipose tissue. And the dissection is performed similarly on the left side with accompanying wide margins. This is important given that one study found that 25% of patients presumed to be stage 1 or stage 2 based on preoperative imaging and intraoperative inspection and palpation were actually found to be stage 3 after pathologic examination solely due to microscopic invasion of tumor cells into the periadrenal adipose tissue. If the tumor is simply shelled out from surrounding adipose tissue, this can lead to local recurrence in the tumor bed or peritoneal dissemination. Peritoneal recurrence is associated with the worst outcomes and fastest demise in patients operated on without evidence of metastatic disease at the time of surgery. Dissection inferiorly should include ample, normal soft tissue overlying the superior portion of the kidney to ensure an adequate inferior margin, as shown in this video. If direct invasion of an adjacent structure is suspected or confirmed intraoperatively, en bloc resection should be pursued if this integrates appropriately into the rest of the operative plan. Certain organs are more commonly involved than others. The surgeon should avoid attempting to create a plane between two structures where none exists, as this risks dissemination of tumor cells and local or peritoneal recurrence. Multiple scenarios may be encountered in the way in which the tumor interacts with the kidney, and there are multiple strategies to safely and adequately resect the tumor in an oncologically appropriate manner. In this video, tumor thrombus in the renal vein and other reasons beyond suspected and later confirmed invasion of the superior pole of the kidney led to the decision for en bloc nephrectomy. Given the aggressive tumor biology, invasion of the ipsilateral renal vein, vena cava on the right, or the aorta and celiac axis or superior mesenteric artery on the left by the tumor is not infrequent in patients presenting for initial evaluation of adrenocortical carcinoma. Vascular involvement by malignant pheochromocytomas is much less frequent. When identified on preoperative imaging, a decision about resectability in concert with other findings must be made. If direct invasion is identified at the time of surgery, en bloc resection of the tumor with the involved segment of vasculature with or without an accompanying organ should be pursued if feasible. Surgeons should avoid transecting the tumor to remove the majority of the mass and then subsequently address the vascular component. Intraoperative ultrasound is a helpful adjunct to assess for intravascular thrombus. The adrenal cancer operative standards are the first to define a system of nomenclature for extent of venous tumor thrombus involving the renal veins or inferior vena cava. This nomenclature mirrors the system utilized for renal cell cancer. The level of extension of tumor thrombus is important to understand during initial evaluation and preoperative planning, as it indicates if and what type of venous or circulatory bypass may be required. After removal of the tumor, surgeons should avoid morcellation of the tumor, as this impairs the ability of the pathologist to adequately examine the tumor and the periadrenal soft tissues. The tumor margins should be marked with suture and oriented for the pathologist. Use of a synoptic operative report is recommended. A synoptic operative report for adrenal cancers, which can be implemented into an electronic medical record system, will be made available through the American College of Surgeons in 2024. Patients with evidence of autonomous cortisol secretion should be tested for adrenal insufficiency or empirically provided steroid supplementation depending on the degree of severity. The final pathology should be reviewed by a multidisciplinary tumor board and recommendations for adjuvant therapy made, including consideration of ongoing clinical trials. Given the rarity of the disease, referral to a center seeing greater volumes of patients with malignant adrenal tumors should be considered. Patients should be provided information about adrenal cancer and safety information about adrenal insufficiency or crisis and medications according to the individual situation and referred to survivorship clinic and other relevant support services. 3 key questions are addressed within the operative standards for adrenal cancer surgery, including the question of surgical resection in patients presenting with stage 4 ACC. Caution should be exercised before offering surgery to any patient with metastatic ACC. The data is of extremely low quality due to selection bias and heterogeneity of treatment. Debulking should rarely be pursued except in highly selected circumstances, and good control of hormone excess is often achievable when managed by experts. While there is agreement that locally advanced tumors are best removed by a traditional open surgical approach, one of the greatest areas of debate in treatment of adrenocortical cancer has focused on operative approach for stage 1 and 2 tumors. Review of the data and expert opinion within the Operative Standards Writing Group finds that completion of the key technical steps is best facilitated by an open approach. If a minimally invasive approach is taken in small tumors, the surgeon must have not only considerable experience with adrenalectomy in general, but specifically with resection of adrenal cancers. Given the rarity of the disease, the number of surgeons meeting this criteria alone are few. In addition, a surgeon's individual outcomes must also be equivalent between minimally invasive and open approaches in terms of success in completing the key technical steps, incidence of R0 versus R1 or R2 resection, avoidance of violation of the tumor capsule and/or frank tumor spillage, and local or peritoneal tumor recurrence for equivalent size and stage tumors as compared to high-performing surgeons. The final key question examined the call by some groups for prophylactic lymphadenectomy at the time of initial resection. While a regional therapeutic lymphadenectomy is recommended, prophylactic lymphadenectomy is not supported by current data. Lymph node basins adjacent to the tumor should be carefully inspected and palpated, especially in the paracaval, para-aortic, and interaortocaval regions, as well as posterior to the renal hilum, common areas of initial metastasis. Any nodes removed should be marked and labeled for pathologic examination, and the same noted in the operative report. In this video, we have provided a brief overview of the key technical steps and key questions related to resection of primary tumors of the adrenal gland. Careful and complete initial evaluation is critical to facilitating appropriate surgical decision-making and care and facilitates long-term surveillance and management. More information about the operative standards for adrenal cancer surgery may be found on the American College of Surgeons website.